Everybody, my name is Mike Reed. I'm a pharmacist here. I've been here 20-ish plus years, primarily inpatient right now. I did a little work in clinic and a little work in peds. I also do some informatics. And today we're going to talk about cancer chemotherapy, anthracyclines, taxanes, Vinca, alkaloids, Epothilones, and really etoposide. And to get people thinking, since it's Monday morning, it's early, have you ever wondered when you order chemotherapy why you order it per meter squared? There's a lot of toxic drugs out there with narrow therapeutic indexes, but this is really the only class of medications that we actually order per meter squared for the most part. So just something to think about when you're ordering it, and something to think about as we're going through the slides. This is just a quick reminder. I know this is second to the last lecture, but we're going kind of back to the beginning. So just to let you guys know, cell cycle phase non-specific agents, the ones on the right, which are anthracyclines we're going to talk about, basically work at all phases of the cell cycle. So they would work on preformed DNA, not necessarily something that's dividing. Some of the other classes of drugs that we have listed on the top actually only function best at certain phases of the cell cycle. So this is just, again, some really quick background. When we think about how tumors grow and how the cytotoxic chemotherapy works, there's Gompertzian growth. So it's slow growth, then it's exponential growth, then it slows, then it plateaus. So it's kind of like an S-shaped curve that's kind of tilted toward the right. And this goes right to the bottom one, Norton-Simon hypotheses. So this is saying that the rate of cancer cell death due to treatment is directly proportional to tumor growth rate at the time of treatment. Totally makes sense. It works on dividing cells oftentimes. So the more cells that are dividing, the more effective it's going to be. The Goldie-Coldman hypothesis is resistance is independent of the chemotherapeutic agent. It depends on the number of cell divisions that occur not only after but before chemotherapy. So the larger the tumor size or the longer delay in initiating chemotherapy, the more likely or more resistant cells that you're going to have. And then the last one is the tumor log kill fractional hypothesis. It states that a given percentage of cells are killed with each chemotherapy administration. So you may get 95% killed with the first cycle. The next cycle, it's not going to kill the remaining 5%, but it should kill 95% of those remaining cells. And this is clearly why we give multiple doses of chemotherapy for multiple cycles. So these are the drugs we're going to talk about. And if Mark Twain was here, he would say that reports of the demise of chemotherapy are greatly exaggerated. These are still very common drugs. They're going to remain common for a long time. And even newer drugs use similar mechanisms of action. So if we think about antibody drug conjugates, oftentimes the toxic payload that does the killing mimics some of these mechanisms. So they have topoisomerase inhibitors, there's SN38, and they have lots of drugs that work on mitotic spindles and mitosis and preventing that in the cells and leading to apoptosis. So jumping into the drugs, we're going to talk about anthracyclines. We'll just pick one of them. We'll talk about doxorubicin for the most part. These are natural products. They're isolated from microbial sources, which all of the drugs for the most part we're talking about today are. None of them were developed or designer drugs or targeted drugs. They were originally found by screening drugs. You take all these natural products and screen tens of thousands of them and find out which ones had some anti-tumor effects in vitro. They're originally synthesized as stable dyes. This does have an effect, like most of them are red, the anthracyclines, so it can color your urine red, pink. Mitoxantrone is blue, so it can color it blue, green. These are also one of the most commonly used anti-cancer agents, and they have a broad spectrum of action, similar in general to alkylating agents and taxanes. And these are the drugs. Just going to point out that there are 3 liposomal products which have different properties, and we'll go over at least one of those. And these are their structures. This is just for people who are interested in structures. If we look at the bottom right, mitoxantrone technically isn't an anthracycline, but it's generally discussed together with them because it has similar uses and similar mechanisms of actions. If we look at daunorubicin and idarubicin, these tend to be used more often for hematological malignancies, whereas doxorubicin and epirubicin might have a little broader spectrum of action and are oftentimes used for solid tumors. So they have multiple mechanisms of action. They induce the formation of covalent topoisomerase 2 DNA complexes, and this prevents religation of the DNA, causing strand breaks. They also have this intercalation between base pairs, and it inhibits nucleotide replication, and they produce these free radicals, these highly reactive free radicals that add to cytotoxicity, as well as the toxicity or side effects of these medications. And just as a note, that mitoxantrone has a decreased ability to form oxygen-free radicals. This is just a schematic for people who are visual learners. This just shows that topoisomerase 2, you can remember 2 has the double-stranded cuts, and it's 4 base pairs apart, and it forms this covalent bond with the DNA, and it makes it like extremely difficult for the DNA to religate, to get back together. And topoisomerase 2 inhibitors are one of the most potent inducers of apoptosis. This is the second mechanism of action. At the bottom, deformation of DNA by intercalation. So if we look at the red arrows and we have those little black rings there, those are the heteroplanar rings in the molecules, and they get inserted into the DNA strands, and it causes these torsional changes on your sugar ribose background. And it makes it much more difficult for enzymes involved in transcription translation to bind to the drug. And again, that leads to apoptosis. If we look at resistance, it's due to, there's several different mechanisms. It's decreased drug accumulation due to P-glycoprotein, which is the pump. It's an MDR gene product. And they also have multiple resistant protein. That's another gene product. We have downregulation or mutations of topoisomerase 2, increased neutralization, and mutations in P53. And I had actually just found this out last week. I learned that from a resident, that elephants actually have 20 types of P53, and this partially explains why large mammals, who you would expect to have many more cells than we do and many more cell divisions, would have higher rates of cancer. But elephants actually have pretty low rates of cancer, and it's thought to be contributed to the multiple copies of P53 that they have versus humans that have one. Overexpression of antipoptotic molecules such as BCR2 and or BCL2. Mitoxantrone is also not transported by P-glycoprotein or the MRP pump, so resistance occurs due to alterations of topoisomerase 2. And this is just a schematic just to point out that these pumps, that if you're exposed to one class of chemotherapy agents, so you could be exposed to taxanes, they become much more common and divide or develop in the tumor surface, and then they can pump out and decrease the concentration of other structurally non-related drugs, hence the term multi-drug resistance. These are the indications. We're not going to go through all of them, and for the most part, I have very few doses in that we're going to review. Just to point out that the drug's been around for a long time, and there's lots of indications, and it has a very broad spectrum of activity. So just quickly jumping in, HP is a 35-year-old male, stage 4 Hodgkin's disease. He's receiving ABVD. The drugs are listed here. And concurrent radiation to a large mediastinal mass. He comes to the oncology clinic to receive his 5th cycle and complains of tachycardia, shortness of breath, and a non-productive cough. Pulmonary exam reveals neck vein distension, pulmonary rales, and ankle edema. And he's currently on amlodipine for hypertension. So when you think of anthracyclines, one of the first things that should, come to mind is cardiac toxicity. So you have acute or subacute injury that occurs actually during or right after treatment. We have chronic cardiac toxicity results in cardiomyopathy. This is really the most common form of damage and clinically the most important. And there's also late onset cardiotoxicity that results in interventricular dysfunction and arrhythmias. And this can happen years to decades after treatment. So the acute toxicity, we don't put people on telemetry, and for the most part, it can result in nonspecific ST T-wave changes. Sinus tachycardia is the most common one. That being said, there are case reports of serious examples resulting in acute failure to the left ventricle, pericarditis, and several of them have been fatal. And the mechanism of cardiac toxicity, this is really what we're talking about for the CHF type. There's two types, really. Type 1, death through necrosis or apoptosis, clearly not reversible. In type 2, you have cardiomyocyte dysfunction, and this is conceptually more that the cells are stunned and you can get recovery from this. Chronic toxicity typically presents within a year. It says the exact mechanism is unknown, but there's lots of evidence that supports it's related to maybe a little less free radical damage, which is what was traditionally believed, but really to topo 2 damage to the myocardium, and we'll talk about that in a bit. It's related to peak concentration, and this is just a graph. There's almost there's almost 4,000 people here. If we look on the x-axis, it's the total cumulative dose per meter squared, and this is doxorubicin, and on the vertical axis, it's the probability of CHF. So you can clearly see that somewhere around 400 milligrams per meter squared is when you really start seeing these side effects. And just to note that this is personalized. Like, there's some people who you'll see this at 300, and other people can tolerate 1,000 milligrams per meter squared without developing any of these symptoms. And it's kind of hard to predict it. This is just the conversion factor chart. There's multiple different charts available in the literature. And when we're switching drugs, you really want to calculate their previous anthracycline exposure. And this is just saying that doxorubicin, if we arbitrarily give it a 1, daunorubicin and epirubicin are half as toxic, meaning you can tolerate twice as much. And idarubicin and mitoxantrone are approximately twice as toxic, meaning you can tolerate half as much. And for the most part, this is just a rule of thumb, is that bolus infusions have higher concentration, and that leads to increased toxicity. So you can probably tolerate as a continuous infusion 24 hours, twice what you can as a bolus infusion. And this was actually a bolus infusion here. These are just as an FYI, if you're looking to keep track of anthracycline exposure. In HealthLink, you can type in lifetime dosage, and all of the medications that were administered here that we track will show up. So it's a kind of a nice, quick way to be able to do that. Risk factors include higher rates of administration, cardiac irradiation, elderly people, younger people, female gender, pre-existing heart disease, hypertension, and treatment with other drugs that cause cardiac toxicity. And some common ones are cyclophosphamide, trastuzumab, and paclitaxel. And likely there's a genetic predisposition. And as we mentioned, there's a wide susceptibility or sensitivity between individuals. Aggressive risk management is needed. So all these reversible symptoms for cardiac health should be taken. So blood pressure, cholesterol, stop smoking, diet and weight management should all be applied to the patient. And this is from the American College of Cardiology. And I just wanted to point out the monitoring strategies. They're not standardized. There's different protocols, but basically you should get a baseline ventricular fraction, ejection fraction, then after 4 cycles, then after each additional cycle. You can also consider, for example, troponin from longitudinal monitoring. Once the patient completes therapy, they should get their ejection fraction measured 6 to 12 months. And in long-term monitoring is definitely not well defined. And factors you can take to mitigate it, you can reduce the dose if available. You can do continuous infusion. You can use liposomal products. And dexrazoxane, you can use in high-risk patients, and we'll talk about that in a bit. So this patient comes in, he has CHF symptoms, but if we calculated the dose, it's fairly low. So this would be a very atypical presentation for a patient who had 200 milligrams per meter squared of anthracycline exposure. So prevention is key, limit doses, longer infusions have decreased toxicity. We'll talk about a cardioprotective agent and liposomal formulations in the next couple slides. So prevention of anthracycline-induced cardiac toxicity, we know that beta blockers, specifically carvedilol and dexrazoxane, have benefits. There's insufficient evidence to support use of other agents. And this is definitely an abbreviated list. There's a significant amount of drugs that were actually looked at to prevent this toxicity. So dexrazoxane, it exerts its cardiac effect. It's an iron chelator, and somebody figured out that the oral iron chelators don't work, so they looked for different mechanisms, and now it's believed to prevent anthracycline binding to topoisomerase 2 beta, which is which is found in all quiescent cells and cardiomyocytes. So dexrazoxane binds to this, prevents the anthracycline from binding to it, leading to cardiac damage. ASCO guidelines for other malignancies are similar to above. It's for metastatic breast cancer, so it's not for curable breast cancer once people reach 300 milligrams per meter squared. There's really not a ton of evidence with other anthracyclines. It should work given its mechanism, and there are reports that it has been used for some other anthracyclines. The dose is 10-to-1, and you just give a bolus 15 minutes prior to chemotherapy. It's more common in peds. I've probably seen this maybe a dozen times in the 20 years I've been here. Why is it not used? So it does potentiate myelosuppression. There are concerns about interference with anti-tumor efficacy. One large study early on showed that you had more progression. Other studies hadn't been able to validate that, but I believe this is the reason why it was approved for metastatic disease, because it didn't really show the benefit in early breast cancer in that one study. And it's unknown whether it's effective for late onset cardiac effects. So other side effects, bone marrow suppression, it's primarily neutropenia. It can be dose limiting. These are vesicants, so you have to give them IV, and we'll talk a little bit about extravasation. Nausea and vomiting, level 3 or 4, depending on what drugs you're combined with. So you want, oftentimes, your 4-drug regimen, an NK1, 5-HT3, a steroid, and olanzapine. Mucositis and diarrhea, greater with prolonged administration, which is pretty much true for most drugs that cause mucositis, and alopecia is universal. So neutropenia, primary toxicity. So just a quick blurb about growth factors. These are from the ASCO guidelines and the NCCN. So primary prophylaxis is indicated for all regimens that have greater than 20% risk of febrile neutropenia, and also for secondary prophylaxis. So if you develop febrile neutropenia on your first cycle, you should get it your next cycle. You can consider for incidence or risks of 10 to 20%, depending on the patient's factor, age, bone marrow history, performance status, a lot of different things. Usually not for the treatment of febrile neutropenia, but again, it's patient specific, and you should look at patient risks and treatment intent. Oftentimes, if the intent is not curable, it's a palliative type intent, that you would do dose reductions or delays instead of adding growth factor. And benefits of prophylactic use. So you reduce the incidence and severity of febrile neutropenia, you get decreased rate of infection and hospitalization, and you get improved delivery of your full doses of chemotherapy. In addition, there's studies that are looking at that it may actually be cost effective to do this. You may actually save money by decreasing the hospitalizations. There are side effects. So bone pain is the common one. You can use second generation antihistamines to mitigate that. Splenic rupture, I've seen that twice, and that was actually in bone marrow transplant patients who were getting higher doses for mobilization. Pulmonary toxicity with bleomycin, and also the risk of AML or MDS. I put a question mark there because individual studies haven't shown that, but a systemic review meta-analysis has shown that there is an increase in AML or MDS. Jumping to extravasation. So these are standard: stopped injection, aspirate, apply ice. You can use hydrocortisone or hydrocortisone cream. All the slides in blue, we're not going to talk about. Those are just for your information. And we won't go through the details here, but just going to say, upon looking this patient, there was redness and along the tunneled site. It was a Hickman, 1.5 inches. The blood return was established. The nurse attempted to lift the Band-Aid. I copied this right from the note. And the patient complained of pain. If you look at the top, the patient was getting a 7+3 regimen, so they were getting an anthracycline push. It's Friday, 8:15 p.m., and the fellow, gets paged. And it's like, what do we do? They've already done what we previously described. So do you want to give dexrazoxane? So actually, they decided not to do it for this patient, and they came in and did a dye study the following morning on Saturday and found out the catheter was safe to access for the clinical service. And I just say this because I think it illustrates the difficulty of assessing an extravasation. I think you can tell if you have 30 mils or 40 mils and have this, huge bump of chemotherapy sitting there, but trying to diagnose this on the telephone when most people have not seen an extravasation, most of the physicians, which is a really good thing. We use a lot of PICs here, so that has gone down significantly. And I put this in here to remind people that if you do have an extravasation, that you should get a plastic surgery consult, because damage may not be obvious initially. And if you do decide to treat with it, the key is you have to do it within 6 hours. It's a 3-day schedule. I have the doses here. It does require renal reduction. And you take the ice off the extremity for 15 minutes, let the circulation perk up, and then you infuse the dexrazoxane in the opposite extremity. Other adverse effects, facial flushing, which is histamine release, doxorubicin flare, so you can get this red streaking proximal to the site of a peripheral IV, hyperpigmentation, urinary discoloration. Again, depending on which drug, it can be red or blue. And secondary malignancies, so AML, oftentimes in combination with cyclophosphamide, they're classified as therapy-induced AML, and they're treated the same, and they all have high risk. They are a little different, though. If you look, due to topoisomerase 2 inhibitors, they're mostly balanced chromosomal translocations, and they oftentimes happen sooner, like within 2 years. If you're looking at alkylating agents, which cyclophosphamide is one of these, oftentimes they have deletions 7p or q and 5, and they also have a myelodysplastic picture, and oftentimes this happens between 5 and 10 years. Radiation recall usually happens within a week. Oftentimes it's the skin. It's more severe if it happens to be the esophagus or GI tract. Kinetics, extensive liver metabolism, you need to reduce the dose when you're giving this. And renal insufficiency, probably not necessary. The doses adjustments are different for the different anthracyclines, so you have to look each one up. This is just a reference here. It's a good hepatic renal adjustment if anybody is interested. And we have a 39-year-old HIV positive male, presents with a rapidly growing retroperitoneal mass. He has extrahepatic biliary obstruction. He has evidence of tumor lysis syndrome. The plan is to start hyper-CVAD. Drugs are listed here. He has an unclassified B-cell lineage lymphoma, has some Burkitt's features. Bili's elevated, uric acid is elevated but down from the outside hospital, and creatinine is improving. So this is the regimen. And does anybody want to throw out there what they would do? Are we going to give this? Are we going to reduce doses? Or are we going to pick a different regimen? Oops. I don't see the chat, so I'll just go ahead. So this real patient, so it was decided to give dexamethasone and cyclophosphamide, which really didn't require the hepatic adjustments. Hold off on doxorubicin and vincristine, and reconsider if he responds rapidly. The patient also got rasburicase. He got 6 milligrams. Today we'd probably give 3. Start him on allopurinol. Uric acid comes down nicely. I don't know if you guys talked about that, but just a couple quick pointers here is you need to order uric acid lab for patients on rasburicase. So it's an enzyme and continues working in vitro. When you order it for patients on rasburicase, it's put on ice and it's processed differently. If you don't do that, you're going to get an artificially low uric acid. You can have anaphylaxis, avoid in patients with G6PD deficiency and methylglobinemia as a side effect. If we look at the liver function tests for this patient, they are trending down nicely. The Billy is down to 2.2, and the patient did end up getting the vincristine and doxorubicin on day 3. So liposomal, we're going to just quickly go through this. Since the drug is in a liposome, it is less cardiotoxic. The conversion is not as firm as I would say the other non-liposomal ones, and you do get a different toxicity profile. You get palmar plantar erythrodysesthesias, dose adjustment may be necessary, and stomatitis can be a dose-limiting toxicity. And again, not interchangeable with conventional doxorubicin, meaning on a 1-to-1 you can't do that, but people have been switched to liposomal products when they can't tolerate the non-liposomal product. This one I'll just mention because I find it kind of interesting, is this is a combination. Vyxeos is the brand name. It's daunorubicin and cytarabine. The standard treatment for AML intensive induction is a 7+3 regimen, so 3 days of an anthracycline, 7, which is a bolus, and 7 days, 196 hours of continuous infusion cytarabine. And this was designed to keep the two drugs in this liposome in circulation. It's taken up by the bone marrow and then taken up by the leukemic cells in the bone marrow, and it releases the drug at the 1-to-5 molar ratio, which is the optimal ratio for killing these leukemic cells. And it is approved for adverse risk AML, which would be therapy induced and previous myelodysplastic changes. It does have toxicity, as you would expect, bone marrow toxicity, but it should have other less limited systemic toxicities. This one we're just going to quickly go through. This is a patient who is ovarian cancer. They had a TAH-BSO. They're starting cycle 1, day 1 of carbotaxol. They experience a reaction. They get a steroid and an antihistamine. They restarted it. They get dull pain, nausea, cold, clammy. Infusion was stopped. Restarted again, and they get a rash. The carboplatin wasn't given. These were reactions to paclitaxel. Then again, the next time they started doxorubicin, so the patient became flushed, chest heaviness, again, steroids and antihistamines, and then she noticed a rash on her chest through the carboplatin. So the patient experienced some type of infusion reaction with their carboplatin, with their paclitaxel, and with their doxorubicin. So 3 of the main drugs you're going to want for ovarian cancer. They decided to do doxorubicin and carboplatin. These were the orders, and the patient actually said, "This is wrong." And she actually had this sheet with her, which was written in her chart. There are mechanisms to desensitize, or protocols to desensitize doxorubicin and also carboplatin. And she was astute enough to say, "We can't do it. You have to do this." And if we look at this, there are 3 different concentrations and 12 different dose escalations. So it either has to be started in the morning in clinic, or it has to be done inpatient. So then there's order sets for these. And actually they require 3 orders like this. So mitoxantrone, I'm just going to mention dose limits leukopenia. We talked about the cardiac toxicity, and it does have blue discoloration of the urine. That's a picture of the actual drug. So it's blue as opposed to most of the others that are red. Azole drug interactions, I just want to mention one drug interaction, and that's with azole antifungals. The one we would see most commonly is with posaconazole. Inhibits the metabolism of the anthracyclines. So on a 7+3 regimen, we would give the posaconazole starting day 4 when the anthracycline is complete. And it's interesting, if you look at this in lexicon, this interaction doesn't show up. All right, quickly go to etoposide, again, from a natural product. Mayapple mandrake's been used for thousands of years, actually. It's a 2nd generation semi-synthetic. It's non-intercalating, so it's a pure topoisomerase 2 inhibitor. These are the indications that we have listed here. And it is the only drug we will talk about today that can be given orally. It has approximately 50% absorption. So really what that means is if you're getting 100 milligrams per meter squared IV days 1 through 3, for your lung cancer, and you want to do it orally, you just give 100 milligrams per meter squared, the same dose, you'll just give it twice, once in the morning and once in the evening. It is highly protein bound, partially leading to its hepatic adjustment. And it does cause hypotension if given too rapidly. And this is more common with high dose therapy that you see in a conditioning regimen rather than a 100 milligram per meter squared dose. Oral capsules, like I said, it is available in a 50 milligram capsule. And myelosuppression is the dose limiting toxicity with conventional dose therapy. It's reversible, it's non-cumulative. The neutropenia here is basically 1 to 2 weeks. Mucositis, stomatitis is the dose limiting toxicity with high dose therapy. So you can have a 50% incidence with high dose therapy. People get metallic taste during during their infusion, and we talked about secondary malignancies, oftentimes the balanced chromosomal translocations. And these are just some other ones. People can, I think there's alcohol used to formulate this drug. It's a natural product, so people can have reactions and bronchospasms. And it does require a renal adjustment, and it does require hepatic adjustment. All right, moving on to the taxanes. So these were originally from the Pacific yew tree. I remember there was controversy at the time when this drug was being studied. So way back in 1992, when I was just an intern, the trees had to be cut down, and I can't remember if it was per dose or per cycle, but these old growth Pacific yew trees in the Northwest, they had to cut down 3 of them to get this product. It is a complicated molecule, so it wasn't easy to synthesize it. It can be done now, and you can use needles from a European yew tree. And they are part of the reason people react to the taxanes is not only the taxane molecule, but the formulation. Paclitaxel is in Cremaphore-EL, which is a polyethylated castor oil. It has ethanol in it, and docetaxel is polysorbate 80. Docetaxel should theoretically have less infusion type reactions, although lately with the product we have, that doesn't necessarily seem to be the case. So these promote the assembly of microtubules from tubulin dimers. They stabilize them, prevent depolymerization. This stability results in inhibition of this normal dynamic reorganization required for interphase and mitotic cell functions, and it basically blocks mitosis. And this is just a quick schematic, and not a great one now that I'm looking at it, but the taxanes at the bottom, they form these non-functional microtubules, so the cell can't really proceed through mitosis, which is different than the Vinca alkaloids, which we'll talk about. This is a co-pilot version. I just tried it. It took a minute to do this, so I have no fear that AI is taking over the world as we speak. The resistance is the multi-drug transporters, and also altered alpha and beta tubulins, and upregulation of enzymes that metabolize taxanes. Again, we're skipping all the blue. This is different than docetaxel. Paclitaxel has a disproportionate increase, probably due to the solvent, meaning especially at higher doses, if you increase the dose 25%, you may get a 50% increase in exposure or area under the curve. Likewise, if you have to be on that part of the curve, if you decrease it, you may get a disproportionate decrease. Docetaxel is linear throughout the normal dose range. Hypersensitivity, one of the things that red flags should pop up when you're giving taxanes is when the paclitaxel first came out, approximately 30% of people reacted. They developed a protocol based on, I think it was a Cleveland Clinic, but a radiology contrast allergy protocol. Here we have the mild symptoms. It's possible to complete under close supervision. Moderate symptoms, you really want to give antihistamines and steroids, and you can probably restart that. If you have the severe symptoms like respiratory distress requiring treatment, so epinephrine or bronchodilators or generalized urticaria, angioedema, you want to give the rescue medications, but for the most part, you're not going to re-challenge. There are people who have reacted to paclitaxel that have tolerated docetaxel, so it's not a one-to-one. If you're allergic to one, you might not necessarily be allergic or react to the other one. Pre-meds for preventing hypersensitivity, dexamethasone 12 and 6 hours prior to chemo, and diphenhydramine and famotidine prior to the chemo. And there's different protocols to decrease the amount of dexamethasone for some steroid sparing, as people are getting multiple cycles of these. If patients come in and they forget their dexamethasone in the morning, oftentimes it's just 20 milligrams of IV dexamethasone that you can give the patient, an hour or 30 minutes prior to their infusion. Bone marrow suppression, we kind of talked about growth factors here. Neutropenia is a dose-limiting toxicity. It does depend on the schedules. You have less toxicity on smaller weekly schedules than you do if you have the higher doses, or also if you have docetaxel, tends to be higher. We talk about peripheral neuropathy. Okay, so majority of patients, 27 to 60, have some type of neuropathy. It's numbness and paresthesis, glove and stocking distribution. It's due to axonal degeneration and demyelinization. The nerve body is generally spared, so oftentimes people usually will recover, and it is similar to what you'd see in Vinca alkaloids, but less severe. So chemo-induced peripheral neuropathy, we'll just do a quick case comparison here between two drugs. Paclitaxel, acute symptoms oftentimes peak 2 to 3 days after your dose. Oxaliplatin, similar 2 to 3 days after your dose. Paclitaxel, oftentimes it's pain, the truncal hip area. Oxaliplatin is cold sensitivity, throat discomfort, muscle cramps. Paclitaxel tends to resolve between the doses, whereas oxaliplatin may not resolve between your cycles, especially if you're on a Q2 week cycle. If we look at the chronic toxicity, it's more Taxol in the lower extremities, and oxaliplatin is more severe in upper extremities. And paclitaxel tends to improve soon after the chemotherapy is complete, whereas oxaliplatin may worsen for 2 to 3 months after the completion of therapy before getting better, known as a coasting phenomena. So these are actually from ASCO guidelines 2020, I believe. So chemo-induced peripheral neuropathy, what can you do to prevent it? There's no recommended agents that you can use. You should specifically tell patients not, if they ask. Acetyl L-carnitine is the one, I think it's a chemical, I wouldn't call it a drug necessarily, that actually shows negative outcomes in peripheral neuropathy. So clearly they should not be taking that. And they do mention things that may work in part, but they don't necessarily recommend them. But they, I think, also have a low toxicity. So exercise, cryotherapy, and compression therapy. Treatment of peripheral neuropathy, chemo-induced peripheral neuropathy, dose delay, dose reduction, stoppage, or substitution. So that all has to do with the drug. If you want some sort of intervention, the only one that's really shown to work and has a recommendation is duloxetine, and the dose is 30 milligrams daily for a week, and then 60 milligrams daily after that. And paclitaxel, it's an extravasant, not an irritant, and we have the GI effects. You can see increased triglycerides, mucositis. We don't actually use 24-hour infusions anymore. And you can nail effects along with docetaxel. And these are some less common effects. Although I shouldn't say the less common. Transient elevations in ALT and AST are not uncommon, and alopecia is universal. Myalgias and arthralgias. So you get these flu-like symptoms at doses less than 170. It's usually self-limiting. This is actually thought now to be related to or a manifestation of the peripheral neuropathy. You can treat with non-steroidals depending on what their counts are, or opioids, or prednisone. Docetaxel, lots of black box warnings. So there's a mortality increase with abnormal liver functions. So if bilirubin's greater than upper limit of normal, or AST and or ALT, 1.5 times plus ALK-FOX, you should not give the drug. You need to avoid it. Severe hypersensitivity, as with all of the taxanes, they have this. And the pre-meds that you give for docetaxel, they're in the next slide, but they're a little different than what you give for paclitaxel. And severe fluid retention. If we look, you don't see this with paclitaxel. So you get this poorly tolerated peripheral edema, generalized edema. You can get pleural infusions, dyspnea, cardiac tamponade. It increases with cumulative doses, close to 400. And this is one of the reasons you use dexamethasone. And the dexamethasone it's 8 milligrams twice daily, the day before, the day of, and the day after the infusion. The fluid retention, it's 7% of patients, it's classified as severe, and it resolves slowly. It takes, I think it's an average of 16 weeks to have this resolve. All right. Neurological toxicity, we've already talked about these. Hematological effects, neutropenia is a dose-limiting toxicity. And you get, again, the nail disorders, hyperpigmentation, you get separation of the nail from the nail bed. Again, alopecia, a little less. And renal insufficiency, not needed. Hepatic insufficiency, don't administer for abnormal LFTs. And I won't go through any of the interactions. Cabazitaxel, just quickly, it is, excuse me, it has nausea and vomiting and can have severe diarrhea, hematuria, hematuria, including those requiring medical intervention, were found in the study compared with mitoxantrone, 6 versus 2%, so that's a big difference. And again, GCSF, you can consider that high-risk features. All right, paclitaxel protein bound, just a quick summary. The particles, it has notable advantages. There's some over conventional paclitaxel, lower toxicity, meaning severe neutropenia. You can do shorter infusion times, and in one study showed superior efficacy to the conventional product. All right, moving on to the Vinca alkaloids. Again, naturally occurring or semi-synthetic now. These are old drugs, 1963. Vincristine, more common in pediatric oncology. And just like most drugs that you give to kids, pediatric patients, they tolerate them better than adults. And the periwinkle plant, that's just to remind me that it's from Madagascar. And drugs are similar in structure, but different in their side effects. They all have the neurological toxicity, but they have different dose-limiting toxicities. And it's cell cycle specific. It rapidly binds to tubulin sites, the Vinca domain. It induces conformational changes, basically increasing affinity for itself and leading to formation of these paracrystalline aggregates. Decreases the pool of free tubulin dimers. So as opposed to taxanes, which stabilize the microtubules, these lead to disassembly. And this is just another schematic. We have these tubulin dimers that are removed from one end, added to the other. They bind to the Vinca alkaloid. And these crystalline aggregates that cannot be used. The microtubules can't use these. So equilibrium, it goes toward depolymerization. This is the resistance, P-glycoprotein, MDR pump. Again, you can alter the beta tubulins, and they do share some cross resistance. I have to mention that it's fatal if given intrathecally. This is a black box warning. This is, at one point, this was the most common fatal drug error in oncology. It actually happened here. We had a patient who was in the clinic. The med was prepared in a syringe, which was standard practice at the time. It was labeled over the front of the syringe. I think it said fatal if given intrathecally. For some reason, that label came off. The drug came out of the bag. The patient was also getting IT chemo at the time. And out of a 2 milligram dose, they ended up getting a tenth of it, so 0.2 milligrams. That particular patient did not die, but they also were not able to walk out of the hospital. There's protocols out there if this ever happens, but none of them actually seem to work. So I think the key here is wherever you work is always make sure that the Vinca alkaloids, especially vincristine, are prepared in a bag and not a syringe, which should be standard practice everywhere. All right, so these are potent vesicants. And what is, I think, a little unique about here is if you have extravasation, that you use warm compresses. Most of the drugs you'll use ice. Here you use that to cause dispersal of the drug and minimize any damage. And you can also use hyaluronidase, which basically makes your tissues more viscous and, like I said, allows the drug to disperse. So similar toxicity profiles. We talked about neurotoxicity. It's dose limiting for vincristine. It can appear after 5 to 8 milligrams. It's profound after 15 to 20. And this I just had to throw in there because this is from our cancer center's namesake, Paul Carbone. This was 40 patients. I know 10 of them were Hodgkin's. I don't remember what the other type of lymphomas were. And they treated the patients to basically a toxicity level till they experienced all this pain. And the results, their conclusions were that the maximum tolerated dose, well, first of all, they concluded that the neurotoxicity is related to dose. And then they also concluded that the maximum dose is 0.05 milligrams per kilogram. And if you look at that for an 80 kilogram person, that's 4 milligrams. That's twice the dose that we would believe any patient would ever tolerate now. And I think part of the reason was back in 1963, they did not have a lot of options, so they tried to maximize the therapy that they did have available. 10 of the 10, all the Hodgkin patients did have some response. This is probably, looking at drugs for dose reductions, that you see most commonly reduced, oftentimes to 1 milligram per meter squared, or 1 milligram, I should say, or else holding the dose. These are the toxicities we talked about. It sensory changes don't usually or necessarily warrant an immediate reduction in dose. Loss of motor functions does result in discontinuation. And there's really not any good pharmacological treatment to reduce those doses. And these are just risk factors, which seem pretty straightforward. And for vinblastine and vinorelbine, neutropenia is the dose-limiting toxicity. You can still thrombocytopenia too, but you can also see the neurotoxicity, but it's less than with vincristine. One thing to remember is actually two things I want to point out on this slide are GI toxicities. So you get autonomic dysfunction, so you get bloating, constipation, ileus, and abdominal pain. So you should make sure that people are on aggressive bowel regimens whenever they're getting these Vinca alkaloids. And the very bottom is SIADH, which isn't really that common. So syndrome of inappropriate antidiuretic hormone secretion. If you have a question on your boards about SIADH and the cause, it's the platins like cisplatin and carboplatin are probably the most common, followed by the Vinca alkaloids, vincristine, and then the third category or group after that would be cyclophosphamide. And usually cyclophosphamide, it's seen at the higher type conditioning doses or graft versus host doses that you would see. Again, we'll skip all these blue. And Vinca alkaloids, they do all require dose adjustments, which is why it was held for the previous patient. And eribulin, just another non-taxane microtubule inhibitor. This inhibits the growth phase without affecting the shortening. Similar adverse effects to vinblastine, and I have the indications listed here. This is just another schematic that shows it inhibits inhibition of tubulin polymerization, but no effect on depolymerization. And this is our last class of drugs, Epothilones, Epipodopyllotoxins is the example we have here. Again, another natural product, soil-dwelling bacteria, Sporangium celosium. It's relatively new compared to some of the other ones. Discovered in 1993, fungicidal macrolides produced. This induces stabilization of microtubules, shown to cause arrest in G2M. It is active against cancer cells that develop resistance to taxanes, who have the resistance due to the beta tubulin overexpression, and it binds to tubulin different than taxanes. These are the indications. I don't see this a lot inpatient. I'm not sure how often it's used in a clinic, but you can use it with capecitabine for locally advanced breast cancer, for patients who are resistant or intolerant to taxanes and an anthracycline, or if they are resistant to all three of them, you can use it as a single agent. There are responses seen in taxane-resistant tumors. As most drugs, it's most effective in patients with minimal prior therapy, and it does have less resistance, or at least theoretically, the mechanisms. It's less susceptible to the MDR, MRP drug efflux pumps, and not susceptible to these tubulin mutations that can develop resistance to other taxanes. Hypersensitivity, it is chromophore EL. You do need H1, H2 antagonists, but you don't require steroids. And neutropenia can be dose limiting, managed with delay and or dose reduction. Peripheral neuropathy, again, primarily sensory. It's cumulative, it should be reversible, and again, managed by dose adjustments and delays. And these are just another list, or more of the less common toxicities. And this is the answer I think people have been waiting for or not waiting for. The first question is, why do we order chemotherapy? First cytotoxic chemo in milligrams per meter squared. It actually comes from some very early research. In this particular publication, they had two drugs. They treated different mammals, mice, hamsters, rats, and men to a level of toxicity, and found out in the right-hand column that what correlated best to the toxicity is the dose per meter squared. So it wasn't flat dose, it wasn't dose per kilogram, it was dose per meter squared. So this kind of started people ordering and developing protocols where they were dosing chemotherapy that way. So really it had nothing to do with efficacy. All right. I do just want to show one thing for you guys, that we won't do it now, but oops. There is, if you have questions and want to review all the key points, not all the key points, I did run my slides through Microsoft Copilot, the AI, and asked it to generate some questions on a level that would be for a heme-onc person taking their boards. Maybe 20% of them came out, so I made up the rest of them. So if anybody does want to do that, basically you can click on the drug, not the drug, the question.